All right, spinal trauma. Introduction to spinal injury, spinal anatomy, physiology, pathophysiology of spinal injury, assessment of the spinal injury patient, management of the spinal injury patient. A lot like head injury, once the damage is done, it's hard to fix it, right? So a lot of what we got to do is focus on prevention and preventative efforts, right? I mean, until we can figure out how to make stem cells grow spines back, we're not going to be fixing people with devastating spinal cord injury, right? It's a much better use of energy and finances to focus on prevention. That being said, still a lot of these are going to occur. And again, here's our culprit population, right? 15,000 permanent spinal cord injuries annually, mostly motor vehicle crashes. Falls makes up a significant amount. Penetrating trauma, much less significant. Sports injuries. 25% of all spinal injury occur from improper handling of the spine in patient after injury. I'm not sure I believe this number. I think what this probably represents is a poor documentation of a neurologic exam in the pre-hospital setting, followed by a detailed documentation of a neurologic exam in the hospital setting. And so what they say is, well, you didn't see it there, we see it now, it must have happened on the way in. When truthfully, it probably was there but not recognized. So I think this is probably an inflated number, but what it does highlight is how important it is to capture spinal cord injury and be thorough on your exam, right? And in your note, it may even behoove you to say this is a person with spinal cord injury, gross initial exam doesn't demonstrate, finer detailed exam is deferred to the hospital setting. You know what I mean? Some sort of thing in there that says, hey look, I didn't do the most detailed neurologic exam because I got a trauma patient that needs to be transported who's got an obvious injury. So I did a gross exam, right? And we transported with all spinal precautions, ensuring that we didn't create any additional injury, and then turned them over and relayed that message to the oncoming team. I bet you this number is inflated though, okay? I have a hard time believing that we create 25% of spinal cord injury. There's 33 bones that comprise the spine. It provides skeletal support. It's a portion of the axial skeleton, a container for the spinal cord. The vertebral body is the main weight-bearing component of the spinal column, and it sits anterior to the other vertebral components. So here is my vertebral body, the major pillar weight-bearing portion, right? I have the spinal foramen, where my spinal cord inside the dura sits, right? So that dura mater extends all the way down through here and houses my spinal cord. You'll start to see as I go from the lumbar to the thoracic to the cervical to my atlas that I'm going to start involving vasculature in here. So I've got channels for and the transverse foramen where I'm going to have vertebral arteries. This is where you can have vertebral artery injury along with spinal injury, okay? So you can get stroke-like syndromes or particularly this is mostly posterior circulation, so people with vertigo and head injury or neck injury, I always worry about the possibility of vertebral artery injury that goes along with it, okay? So 7 cervical vertebrae, 1 through 7, the unique characteristics of the atlas and axis we'll talk about. Then I have 12 thoracic vertebrae, all of which articulate with the ridge, or with the rib. 1 through 12 articulate with the rib. And then my lumbar vertebrae and my sacrum and coccyx, okay? C1 and C2 have no vertebral body. They allow for a large amount of range of motion, right? If they were designed to look like my lumbar spine, then we all look like we had spinal fusions, and we'd be talking like this, right? Like, hey, how you doing? They'd say, hey, you untied your shoe, and we all look like this, right? So what it does, the beauty of the atlas and the axis, is that it provides a lot of range of motion and a lot of mobility. But it is susceptible then to fracture because of that, right? So extreme ranges of motion, and particularly as I age, I'm going to have certain areas that are vulnerable to fracture. We'll talk about that a little bit. The more as I drop down and I go inferiorly in the spinal column, I become more of a kind of a bulky, supportive, structured vertebra, in the lumbar spine being the largest weight-bearing portion there. Sacrum and the coccyx are vertebrae that have been fused. They have no vertebral body. If we were puppies, we'd all have coccyxes that spread out into our nice long tails, right? So that's your tail. So components of the vertebrae, the spinal canal, this houses our spinal column, right? Our pedicle is a thick bony structure that connects the vertebral body to the spinous and transverse processes. So this is my pedicle here on either side. So the pedicle attaches the posterior segments with the anterior segment. The lamina is what kind of supports the various processes and makes up the posterior margin of the spinal foramen. Transverse processes and the spinous process allow for articulation with ribs, but also attachment of the muscles that provide us some support and structure there. When I stack these on top of each other, you can see where they articulate, right? So you get an articulation here that kind of at the superior articular process, and then I get an inferior articular process that it sits down here, and then I have the emergence of my spinal roots that come out of those foramen that exist, and it fits together nicely, just like over here on our headless horseman. And you can actually, why don't we grab that spinal stuff there and pass it around easily. In between there, I have an intervertebral disc that acts as a cushion, right? You've all heard of people with herniated discs. Herniated discs, they hurt and it kind of gives them pain down their leg. Well, typically what that is that disc ruptures and then impinges on that nerve root. And then I have impingement to that nerve, and it gives me neural pain or radicular pain that runs along the distribution of that nerve, okay? I have various ligaments. I have an anterior longitudinal ligament that holds structure on the front portion of the vertebral body. I have a posterior longitudinal ligament that sits right behind the vertebral bodies. And then I have intertransverse ligaments, supraspinous ligaments, intraspinous ligaments, the ligamentum flavum, which is a very strong ligament that provides some support as well. So in addition to the bony component here, you can see that if I have disruption of these ligaments, I could have instability of the spine. Even without spinal bony injury, I can have significant instability if I impair the ligamentous structures there. Does that make sense? The cervical spine, there are 7. Their sole weight is for support of the head. I don't know why I just thought of this. What's the movie, So I Married an Axe Murderer?
I love that movie.
And I'm just imagining the dad talking about the boy's head. Head, and then he calls him head. His boy's head, it's like splitting it, right?
You could put it on a toothpick.
If you haven't seen it, you should do it. Some weekend when you're looking for something to do, you should read Salt or Cod and then watch So I Married an Axe Murderer. And dissect an animal, right? Is that the other one that we learned
Go
today?
kill a deer.
Yeah, go kill a deer. So, C1 Atlas supports the head. It securely fits on the occiput. So your foramen magnum is what sits right above this, right? C2 is the axis. This portion of C2 is very unique. It's called the dens. And this, it becomes very susceptible to injury, okay? When you're young and healthy and you've got strong bones, then you can take a lot of damage to this area and not fracture. But think about kind of an old wagon wheel, cog wheels, and it sticks. and you don't get smooth rotation there, right? Or any sort of thing that's not well lubricated. Well, as I age, what I get here is so this sits up inside here, and I have a ligament that wraps around and kind of seat belts, almost like seat belts that bends in place. Okay? And what happens is that gets, as we age, that will calcify, and so it'll start to stick and it gets less lubricated. So instead of having a nice lubricated function there, what I'll do is I'll kind of get a little bit sticky. And not only that, I end up with a thinning of the bone, osteoporosis, right? So I get a very susceptible region for injury right here. So, and it's not always painful, okay? So what happens is you get your little old lady who trips and falls, and she hits her head on the nightstand when she's going down, and she twists. There's a rapid rotational movement to the head. She hits the ground. She looks okay except a little bruise on her chin. She didn't lose consciousness. She moves everything fine. Doesn't hurt. Doesn't hurt when I press here. No neurologic deficit, so she doesn't get a C-collar or a backboard. And every year there's a couple that come in with a C2 fracture, which is potentially unstable. It didn't hurt. That's why the local protocol says trauma above the level of the clavicles in somebody 65 or older, even with a ground level fall, should be in a cervical collar. Because it's this frail, sticky little ligament, and if I have a quick rotational movement, which is indicated by trauma on my head, right, above the clavicles, then that indicates that I had a quick rotational movement during that fall, and they're very susceptible, and they won't always hurt, okay? It makes sense? So very susceptible little spot for injury.
Where's the dent at on these things?
On C2. That's not C2. That's probably thoracic spine there based on the look of it. But if you come up here and you look at it, you can see where it sits. It's only up in C1 and C2, right? So the only place I'll see it is at C2. So up here, it's actually got a screw coming right out of it. And you come up here and look at this at some point, and you'll see exactly what I'm talking about. It's the only place that the dens exist. It's a very unique design of C1 and C2 together, okay? Is there another spine somewhere? We used to have a spine.
Anterior or posterior portion of it?
It is on the anterior portion. On the anterior portion, not right up front. We used to have a spine. Where is that?
I can't tell.
What is the spine off?
The dens? The dens? Well, this is the axis and everything else.
But do that again.
Bubble heads. Thoracic, cervical, or lumbar.
So yeah, they show a picture of that in there, right? Good. Okay. So thoracic spine, 12 vertebrae. First rib articulates with T1. A little larger, a little stronger than the cervical spine. Really, a lot of their function is not necessarily just to support weight, but also to support the bony structures of the thorax, right? The lumbar spine, major weight-bearing portion of the spine is the thickest intervertebral discs, the thickest vertebral bodies. The sacral spine fused, plate-like formation in the back of the pelvis. We talked about that. Okay, blood supply to the spinal cord. So you get paired spinal arteries that branch off vertebral, cervical, thoracic, and lumbar arteries. They travel through the intervertebral foramina, and they split into anterior and posterior arteries. So this is essentially what it looks like. Okay? So I have these branches of segmental arteries that come out of the aorta, and they come around here, and they have blood supply that come in, and they supply the muscles, the bone, but also the spinal cord. So rapid deceleration injuries, where I have this column of fluid that has weight, and sometimes pull away from that vertebral body, and I'll shear off right here. The other place where I'll see these types of vascular injuries are in dissections, where I dissect down the aorta, and I shear off those spots. So you can get some of these ischemic injuries to the spine with rapid deceleration or with dissections. Okay. In terms of the spinal cord within the canal, I have I had 7 cervical vertebrae, but I have 8 cervical roots. It's because I exit above and below of my cervical spine, but then only below everywhere else. So I get an extra, I squeeze out a little extra spinal nerve in here. So as I come down with my spinal cord, this is the difference that I'm going to see. So I come down and then eventually I taper out into what's this area that essentially terminates into a bunch of strands called the cauda equina, or the horse's tail. So after about T12, L1, I'm not so much a solid cord, and this picture doesn't depict it well at all. I'm more of a bunch of fibers that looks like a horse's tail, of spinal roots that descend down into my lumbar vertebrae and then down into my sacrum. Okay? The cauda equina. C1, 2, 3, and 4 make up my cervical plexus. C5 through T1 make up my brachial plexus. Lumbar plexus and sacral plexus are T2 through L4, and these are just when we start getting into neuro exam, we'll kind of identify which ones of those are important. C3, 4, and 5 keep the diaphragm alive, right? So injuries above those levels are why you don't breathe. Okay, if I can't breathe, then this is why spinal cord injuries above that level are bad. This is why I can survive a low mid-C spine injuries, because I can still breathe, but I can't do anything else. Because C4 and 5 keep my diaphragm alive. The brachial plexus is what gives me function for eventually my axillary, musculoskeletal, radial, median, and ulnar nerves, so the functions of my hand, right? Flexion, extension, hand grip, ability to spread out my fingers, all the sensation along my arm is all within C4 or C5 to T1. L2, what is it? L3, L4, keep your legs off the floor, I think is how it goes. So it kind of gives me motor function in my legs, right? I'm not testing anything T2 to T11 because all it does is like these muscles in my chest, right? And I don't really test muscles in my chest, right? I mean, I can't say flex. Essentially, I'd be like using my accessory muscles to breathe. That's all so it's really lousy for an exam until I get into sensory exam, and then I can start kind of marking dermatomes. So I mark with a pen. Can you feel this? Can you feel this? Can you feel this? No, no, no. Yes, I can feel that. Well, I know that T4 is right on my nipple line. Okay, so that's one that I remember from a sensory standpoint, because from here to here I just rely on sensory. Okay, outside of my brachial plexus, my lumbosacral plexus, I just rely on sensory to see where my injury potentially is at. So I march up. I know my umbilicus is T10, my nipples is T4. So I just kind of march up, it's right here, so I'm about halfway between my umbilicus and, well, I'm closer to my umbilicus, so I'm gonna say T8, right? So I'm gonna guess my